All right, good afternoon. My name is Lauren Rabinowitz, and I am here on behalf of, alongside Neil Horn, who most of you probably know. He can't be with us today. He and I are the co-leads on early childhood for the TA network, and we are really excited to be continuing this learning community for early childhood. Hopefully some of you were able to join us last month when we spoke with Nikki Edge in Arkansas, and she gave us an excellent talk on the mental health consultation system in Arkansas. And today we have something really exciting for you, and just want to let you know you are all in for such a treat. So we have Linda Delimata from Illinois, and she is going to talk to us today about her program of basically an infusion of home visiting and mental health consultation. And they have a really unique model that has been working well there. And I'm excited for you all to hear from her. So without further ado, I am going to turn it over to Linda. If you have just a minute to chat into the main public chat, we'd love to hear where you are from, just so we can get to know the folks that are on the line. Also, feel free to use that public chat if you are having any issues with the audio or anything with the webinar format. We have Gary on the line from the TA Network as well, who is handling all of our audio-visual needs. So without further ado, I'm going to hand it over to Linda. Take it away.
Thank you very much. So I am excited to see there are several people on the line from Illinois, and someone from El Dorado and someone from the Egyptian Health Department in very southern Illinois. So welcome, everyone. Today we're going to be talking about implementing mental health consultation into home visiting. And so we're going to get started with that right now. I'm going to move us to what is infant and early childhood mental health. Whenever I use those terms, people are very confused, mainly if they're not in the field. And they'll say, what happens with an infant that they may need therapy? So, of course, that is not what infant mental health is. It has nothing to do with therapy. In fact, we know that babies in isolation should not even be considered, that we are looking at a child within their entire environment. So what is the whole concept of infant mental health then? We get a definition here, and this comes from Cohen, and it says that infant mental health is the developing the capacity of the infant and toddler to do those things we know they need to do as they grow. So the first one is they need to have very close and secure relationships. They need to be able to experience, regulate, and express their emotions. That's a huge piece of what all of us need to do. And little ones need to grow and be able to understand and in relation to other people through their relationships, their emotions. And then they have to be able to explore their environment around them and grow and learn. And nothing is done in isolation. Infants are and babies are, everything they learn is in the context of their family, their community, other people around them, and the cultural expectations of them. So it is all about relationships and learning and growing. Just a second. There we go. And so consultation then, that's where a consultant is someone who has some credentials along the lines of mental health and early childhood development, and we'll talk about that later, that they come together and collaboratively work with people who are in the field. And in the thing we're talking about today, it is those home visitors and the supervisors that are the target of our conversation. So working with home visitors and the programs and the families to be able to prevent, identify, and respond to mental health issues in the children in their care. The focus of mental health is of infant early childhood mental health consultation is something that we're going to talk about in this next slide. So it is always relationship-based. Everything that we talk about is relationship-based. We try to keep in mind the children and that they are not in isolation. Everything that they do is within a system. So we look at the whole family and the child, the parent, and their whole environment. And we always keep this strength-based. We focused on the capacities, the things that can be encouraged and developed. It's always individualized because no child is the same as another. No system is the same as another. No relationship is the same as another. So the work isn't done with everything uniform. It's within a system, and it is directly related to that particular child or home visitor or program. So it's always individualized. One of the things we know about infant mental health is that it should be consistent. It should be predictable. It should be something I can count on and I can move forward with. So it needs to be continuous and stable. And absolutely, it should be culturally responsive, understanding the culture of the families, the communities, and of the program that you work with. And always stress the importance of being self-aware, being able to reflect, and knowing that we need to move and grow ourselves as professionals. So this is a huge piece of work, and it's very complex and demanding. And there's always, it's fluid, and there's always change going on. So when people are working in this field of home visiting, there's so much that they have to hold and so much that they have to get involved in that a mental health consultant can come in and help them through each of the areas. They can help them as they do their work. Some of the benefits we find with consultation, one of the first things is that it gives you a place to talk about cases. So you may be working with a family and a child, and you've been working with that family for about a year, and you find yourself at a place where you need to think through something that isn't quite going on right. And this is a place, a safe place for that home visitor and that supervisor to go deeper into that case with someone and talk it through, being able to put things on the table. What it isn't is you will not have your consultant saying, here's what you need to do, because that's not what it's about. It's about collaboratively working together to find ways to approach and ways to look at this case. And consultation offers support with very difficult issues. Things that come up that need to be addressed. You might need to walk through it. You might need to have a place that's safe to spend some time taking a look at yourself and reflecting on how you're reacting or responding. So having someone there to support you with those difficult issues is what consultation is able to provide. It also helps to build some skills to address mental health concerns. Sometimes when a home visitor is dealing with some of the very tough things they deal with, and something comes up such as maternal depression, they really need, there's an opportunity here for there to be some support related to those types of issues. Someone who brings with them some mental health support, able to walk through what that might mean, talk through some situations that might come up, and maybe develop a way of approaching someone to ask some pretty tough questions. Or let's say you do an Edinburgh and you find that some of your scores are concerning. Not necessarily we're at the point of referring someone for maternal depression, but we're just a little bit concerned right now. This is a wonderful opportunity to sit down with the mental health consultant and just explore what options are available there. Sometimes I've heard home visitors say, now that I've been doing consultation, I have the words to use that I might not have had before. And sometimes those words are just questions like, oh, tell me more about that. Or, I see that something is concerning you. Talk to me about that. So it is not necessarily anything really deep, but it's just a way to help move forward and to go deeper into issues when they come up. The consultation is so reflective that it promotes the whole idea of reflection and supervision and in your group work. And as we talk about Illinois' model, you're going to see that reflective practice is a big piece of that. And then consultation encourages and supports relationships. As we talked earlier, it's all about relationships. And that the relationship that home visitor has with that child, the relationship that home visitor has with that parent, the parent has with the child, and then the supervisor and consultant have. It's all a parallel process. So it is supporting and encouraging relationships. So reflective practice means that we stop and we look at what's going on. We step back from what's in our immediate work, and we think through what am I feeling, what am I experiencing, what am I feeling about what I see happening, and think through myself and my reactions and what might stand in my way of getting closer, more connected, what this brings up in me, and how I use myself in this work. So many times I think about the work of home visiting and how impactful that work is. It's such an exciting field, and the work of the home visitors is amazing. And you are connecting, you are making deep relationships, you're there with families as they support their children as they grow, and that means that we are using ourselves, home visitors are using themselves in this work. And that is where we can help home visitors sit back and take a look at that relationship and take a look at how we use ourselves. And we can take a look at what comes up when we are dealing with some stuff. So in the field of infant mental health consultation, we have to balance everyone's needs. We have to balance the infant, child, and parent needs with my own reaction to those. I'm just going to use an example. So if you're working with a family and the mom is yelling at the child, and that brings up in yourself issues that were always difficult for you. If you had yelling as an issue and it bothered you so much that you might pull back and not connect with them. You might get upset with that mom. You might get frustrated, and that might stand in your way of connecting with that mom and helping her look at many different ways to work with that baby. So if you step back and say, I'm finding it very difficult. I don't know what's getting in my way, and you talk through that with someone, then you're at a different place. And it allows you to be less, it allows you to be non-judgmental. It allows you to be non-threatening when you've moved those issues that stand in your way and put them in a different place. And you can go back with that family and connect again and be able to deal with those things that may have brought things up in yourself. So you have to be able to explore. You have, as a home visitor, when you're working with families, you have to be able to explore what happens within yourself and to put them in a place so it doesn't interfere. When you're participating in reflective consultation, that supports that self-exploration and an increased self-awareness. So if you dealt with that situation I just talked about in one case, then you may be more aware and able to use that information as you deal with another case when something comes up similar to that. So whatever comes up is something that you can work through and put it in a place that makes it safer for you. So then you have the ability to kind of stop yourself, catch yourself, and you are more in control of your own responses in those challenging situations and able to self-regulate and able to put yourself in the best place to work with that family. So the parallel process is really what this is all about, because the relationship with the staff has with the mother and the family and the baby helps to hold and contain and regulate that family. And it's the same thing. Reflective supervision and consultation help to hold and contain and regulate the staff, the supervisor, and the other personnel. So the very same thing that the home visitors are providing to that family is what consultation is providing to your programs. And that holding environment takes its toll. And it takes its toll on the home visitors. So having a place for them to do the same type of thing helps to build and strengthen and support them as they do this very important and very difficult job. So it's important to be able to think about what this work brings up for you and what you might struggle with in a place that is safe and in a place that is offered to you just for you. So many times in this really tough work, when we work with children and families, it brings up some personal experiences, and it may not even be something that home visitors are aware of. It may just be something that they know is happening, but they can't really put their finger on it. So working with them to be able to get to those, to use their self, to get to those places where they understand what's happening is one of the roles of the consultants. And then that helps them make conscious those things that are standing in their way. And I'm going to use another example. In one of the programs that we provided support to in Illinois, there was someone who was finding it difficult to go into her and make a strong connection to one of her participants. And it was a fairly new participant, but she found herself each time that she went, she came out and she would cry and spend time crying in her car. And through the process of self-reflection and through the process of working with her consultant, she was able to realize that this mom reminded her of a close friend of hers who had passed away about a year prior, and she was having trouble making that connection. But once she was able to identify what was standing in her way, she was able to walk through that. She was able to process that issue, and when she went back, she could start making that connection, which is so important because relationship is what it's about. And it helps us then to kind of monitor our how we respond, and how it makes a very open and safe place then for people to present themselves and talk about themselves. So although we are aware many times that parents struggle with issues related to their babies and their families, it is the same. Sometimes home visitors struggle with issues and relationships with the people they provide services to. And mental health consultation is there to help us think through those things and to help us find out what is standing in our way. I'm going to talk about what Illinois has done through the partnership and where we are right now with some of that. You can find our model on our website, and there's a link here provided to you to link to that, and this lays out the entire site. We'll lay out everything that happens in our model, but I'm also going to talk about that model with you today. We started off providing these supports through we put out some funding, and people would apply to get funding, and then we would fund those programs, and we would go in and provide consultation and make it about a 2 or 2.5 year process. And after a number of years of doing that and evaluating and researching what were the benefits, that's how we designed this model. When McVie entered our community we then started providing consultation to all McV sites. And then through McV, now we serve about 49 sites in our state and our home visiting program. So we're going to talk about what do we do when we walk into consultation and what are the services that we offer. There are more than just the services offered during consultation. There's also the supports and the professional development for the consultants. So in order to be able to do that job well, we have found that those supports need to be in place, and consultants need to be in attendance of those opportunities. So if you look at the slide, these are basically the things that we offer to a home visiting program. I'm going to talk about Illinois' model. Every model has its own way of approaching. Every program has its own way of saying this is what we do, this is what we don't do. So I just want to put that in there. This is what we do through the partnership in Illinois. The first thing is that we do reflective consultation with the supervisor and sometimes the supervisor and manager of the program. Many times those are the same person. The manager and the supervisor is just one person, but other times the manager is different than the supervisor. And so what we provide to the manager is kind of an overview, as well as opportunity to talk about things that are that they need to talk about. In Illinois, we don't have a signed budget and haven't for a year and a half, and that's a frustration, and that's many times the topic of working with the manager. I don't know how to keep going. I'm worried that we don't have any funding. I'm concerned about how to keep my staff supported. We are down 3 staff and I can't refill positions. Those are the type of things you hear when managers sit down and reflect with the consultant. We provide consultation to the supervisor then to talk about issues that they face. And it may be issues about a client, or it may be issues related to the staff. It is typically what they bring to the table that they need to talk about. So just like home visitors might have something that interferes with their connection to a family, that they need to find out what it is and put it in a place so it doesn't interfere. It's the same with supervisor relationships with their home visitors. It is possible that there's something standing in the way of their connection with the home visitor, and they want to walk through that. Or it may be that they want to plan how they're going to move forward on something related to their program. Or they're concerned about a family that they have that they don't know how to go deeper into working with that family. Whatever it is that they bring up is what it is that they do. Sorry, I had to cough. So the focus of what happens in that conversation really lies with the supervisor. And then reflective consultation with the individual staff. In our work with home visiting through the partnership, when we work with the individual staff, we do it in combination with the supervisor. The consultant joins in to the regularly scheduled time for the supervisor to meet with their staff. And they don't do it every time because sometimes that time is devoted to administrative tasks like filling out papers or things along that line. But we do come into part of it. And during that time, you're able to go into cases and talk a lot about what it is that needs to happen with a specific case, or it may be that it's time for the home visitor to spend some time reflecting on their own issues or things that interfere and bringing it back to the work. Or it may be that there's a conflict of some kind. Whatever it is that comes up is once again what happens. But we do that with the supervisor present for a number of reasons. One is that helps support the reflective supervision of the supervisor in a way to observe and practice in that. The other is it's a way to build sustainability so that when the consultant isn't there, the same type of reflective supervision continues to take place. And the third is then everything is apparent. There's nothing that the staff has talked about that the supervisor is not aware of. There are times, though, at the request of the supervisor, that we may meet individually with that staff without the supervisor present, but that is really unusual. It's more often that we do it in combination with the supervisor. And then the consultant joins into the team meetings, and during those team meetings, they spend time talking about issues related to the group, anything that needs to happen that they want to walk through to make sure we're in the same place. And then many times talking about cases in a group situation helps everybody, because if you're talking about a specific case, many times the other home visitors will also have experienced similar issues in their cases. So it helps to do that as a group, and it builds cohesion, and it helps the group process with each other as facilitated by their consultants. We provide professional development to the programs at the request of the programs, and with McV, there are some requirements that we do when it comes to professional development. So someone might ask us to do something related to keeping boundaries. So the consultant will come in and provide that work with the home visitors. But then each time that they come, they have the opportunity to bring up that information and say, you know, we talked about keeping boundaries. How are we doing on that? Where are we with this particular case where you found yourself allowing that person to text you all the time or get involved with you on Facebook? How are we doing with setting boundaries there? So it brings that professional development to another level. It isn't just information, but it's making it come to life. We also do the specific trainings that we're asked to do, like we train on the Edinburgh, we train on Futures Without Violence, we do some training on the 4 Ps, and we are now designing a professional development event for Illinois McV sites, and that is on working with moms with cognitive limitations. So we get our requests from the programs, and then we get our requests from the funders. And it isn't just a training. It is helping that training on an ongoing basis. So let's say we did one on Futures Without Violence, and after they've heard the training, they do a scan, and they work with moms on, you know, how safe do you feel in your relationship, and things along that line. And something comes up, and then we talk about that. The home visitor, the supervisor, and the mental health consultant can process that, and we're all on the same page with the same language. And so every time cases move along that line, that training has taken it another step and gone to a deeper level. Another thing that's available to the homes but doesn't happen very often is that the home visitor is eligible to go on the home visit with a consultant. And the reason it doesn't happen very often is when you add a third person to a home visit, many times the dynamic changes and it isn't helpful. It's easier if they do videotaping and the consultant's able to watch the videotape, and together they can talk about what did we see, you know, process that observation. But there are times when it's important for the consultant to go on that home visit. And that might be a home visitor's concerned about some mental health issues related to the mom, and they aren't feeling comfortable without someone doing an observation with them. Or it may be that they're really concerned about some of the social and emotional skills that the baby's not catching, and they would really like to have someone give another view. So there are times when that happens, but it is fairly unusual. And then we also offer that the consultant can come in to some of the groups that are run and provide support and co-facilitate those groups. Hold on just a second. Sorry, had to cough again. So those groups would not be something that's identified or run by the consultant. But if your home visiting program already has that group established and they would like that consultant to join, that's a time where that is real appropriate. So you might have a group that you're working on which might bring up issues in the home visitors and it just in the moms, and it's just a lot more comfortable for a home visitor to have a mental health consultant sitting with them. And that is something that people take advantage of. So in order to provide all those types of supports, the consultant themselves needs to be supported. So through our work at the Children's Mental Health Partnership in Illinois, we provide these types of supports to the consultants. They get a monthly reflective supervision session with either myself or someone that I've hired to do that work. And during that time, they talk about themselves. You know, here's what came up for me when I was doing this. I'm afraid I wasn't as open and available to this group as I want to be, and I need to talk through why. So the same types of things that we do with home visitors, they need to receive from their supervisor as well. And then we pull together everyone who's in the same project. So, for example, the McV consultants, we pull them together as a group every other month, and we spend a whole day together. And we give them a chance to talk about their programs. We talk about the trainings. We talk about expectations from our funders. But it is a very supportive environment. And sometimes we go into whatever it is that we need to do at the moment, just like you do in a home visiting program. We offer infant mental health learning groups that are provided by the Ounce of Prevention, where the home visitor, the supervisor, and the consultant attend as a team. And one of the programs presents a case, and the rest of the programs have read articles sent to them that are related to the issues in that case. And then there are discussions about what that family might need and what we learned from the articles. That's quarterly. And then every month we have reflective learning groups around our state. And those reflective learning groups are for anyone who does consultation in the state of Illinois. And those are facilitated by masters or experienced consultants, and it is only consultants. And so they sit together and help each other with all of the things that they experience as a consultant. I require the people in our programs to attend those because I think it may be one of the most valuable professional development opportunities they can experience. And then once a year we do a mental health consultant retreat. We talk about what's happening in our state and things that everyone needs to know if they're a consultant. We talk about supports that they can receive during the whole year and from where and whom. But we also provide training for them as well. The one we did last time was on ethics, and the one we're doing this year is on diversity. So consultants need their own time to network with each other, but also to learn and grow and to continue their own education. So over the years we've been doing this, there are a couple of lessons that we've learned that I wanted to go through. And the first thing is every program has their own readiness for consultation. And you can't, it's just like consultation is always individualized, it's the same with the program. We have to individualize our services based on what each program needs. So I just laid out for you what our model looks like, and that turns out to be about 20 hours a month that we provide to programs. Some programs, when they start off, don't want that. I'm not ready for that. I'm okay if you meet with the supervisor and the manager right now, but I'm not ready to move to the next step. So that's what we do. No one forces a whole model on anyone. We hope to get to that model, but we start with what people need. And sometimes people are uncomfortable having the consultant join in on those individual supervisory sessions. So we don't do that at first, but we continue to talk about it, and hopefully at some point we join in. So it's about trust. It's about relationships. So we have to take a really close look at readiness and where people are and what they're open to. It's really important that consultants develop a positive relationship with the program staff. And so sometimes it doesn't work. The consultant is not the right person for that group of staff. So I've learned over the years that matching the consultants with the program is essential. And if it isn't working and they can't develop those strong relationships, then possibly we need to find a different consultant. Every program has their own unique culture and their own strengths, and all of their culture and their strengths inform their philosophy and their practices with families and children. And we want it to be individualized, and we want programs to be able to make whatever they have work for them. But we also want to support them as they do that. So it was for a while that when the partnership put out those RFPs and provided some funding to get a consultant, it was that the consultant started working with the program, and it was maybe 6 months before people really understood what is consultation, how can I use this in my program. So we found that there had to be a pretty in-depth orientation. So each time that we do this now, we start with an orientation for the consultants, which is about 2 days, and then an orientation with the consultants in the program, which is another day. And although that seems like a lot of front loading, it has saved us a lot of time, and it has worked really well. I think that orientation is an essential part of starting any project. We also found that role clarification was real important. People didn't really understand what we did, and they would say, just tell me what to do. I just need you to tell me what to do with that child. But they really didn't. If you tell someone what to do, it becomes you as not a collaborator, not as a partner, and we're not the expert on the kid. The home visitors are. They're the ones that know that baby, they know that child, they know that family, and working together collaboratively with a consultant helps get a much better way of doing things and support to that home visitor and to that family, rather than just saying, here, do it this way. And then I mentioned before a mismatch. There's an art to matching the program with the consultant that meets their needs. It is understanding the culture of the agency and understanding the way the consultant works and finding a way to blend that and make that work. And then we did some programs that were less than 2 years where we put a consultation in, and we found that there needs to be at least 2 years of ongoing reflective work so that the sustainability is in place. And I have found that at the end of 2 years, it still can't end, because the supervisor still needs a place to have some time to talk through things with the consultant. So we built in quarterly time for supervisors and consultants, and there's no end to that. And in the McV program, we've been in those programs since the inception of McV, so almost 5 years, and there doesn't seem to be an end to that either. So 2 years is what we had originally built into programs, but that has flexibility within it as well. I go and do a site visit at each of the programs, and I collect data on all of that. And here are some things that I've learned from home visitors doing those site visits. I hear repeatedly, I understand infant early childhood mental health a lot more now. I understand mental health a lot more now. People say they feel supported and that they love having a place to talk about challenging cases. They like learning new approaches. They like having somewhat of a plan to move forward when they felt like they were stuck. And they feel more confident dealing with mental health issues during visits. I had one home visitor tell me last time I was in a program, I feel like my consultant is sitting on my shoulder, and when those tough things come up, I say, tell me more about it. And then they just keep talking, and in the past, I would have gotten nervous and wanted to answer and fix things, and now I don't feel that way. So those are the sort of things that we've learned as we've worked with our mental health consultation over the years. I want to mention what we're doing in Illinois right now related to consultation. We have pulled together state departments with public and private funders, and we've been doing this for about a year and a half now. We took our Harris Action Plan and looked at what people were saying we needed in the field of early childhood mental health, and repeatedly it was consultation. So we pulled everyone together in our leadership, that are in leadership roles, such as someone from public health, someone from Department of Children and Family Services, someone from Department of Human Services, someone from early intervention, and we have several private funders with us, and we said, what would this look like? What would it look like if we wanted to have consultation uniformly offered through the state? So the first thing we needed to do was design a model. Now, what you just saw was a home visiting model, but we're crossing all systems here. So we're looking at Head Start, we're looking at all systems. So everyone who's represented there, we pulled people together and wrote a universal model. And from that, then we had to say, what would it happen if we put this in place in a number of these different systems? So our next step is to take this model and pilot it in maybe 16 communities around our state, and I mean 16 sites in several communities, larger cities as well as smaller cities or rural, and have this piloted for a number, maybe 2 years, and have an evaluation process in there that evaluates, is this something that has an impact on providers, on your staff, on staff turnover, on families, and on children. So that's where we are. We're designing our pilot right now, and we have evaluators working with us who will then determine how they find out if there's an impact on all of those different areas. It's a real exciting thing to be involved in, and we are just in our second year, and we have a number of years to go before we have any final answer on it. Let's spend a minute talking, answering any questions or talking about things that you might be interested in, so that you can find out more about consultation, or just any reflections that you might have. So, Lauren, can I turn this over to you?
Yep, sure. So thank you very much, Linda. That was a really comprehensive and helpful overview. So your lines are unmuted, so you have a couple choices if you want to ask some questions. You can put it in the chat box right at the towards the left, the right of your screen. You can feel free to just give a shout out. Questions for Linda. Questions about mental health consultation, about home visiting, about how they work together. Give everyone a minute to think. If not, there are a couple questions I had. So, okay. So Natasha is asking, Linda, if you could talk just a little bit more about the quarterly groups that you mentioned.
Sure. So the quarterly group that is the learning group is put together by the Ounce of Prevention, and they pull together programs that are all doing infant mental health consultation, and they're all home visiting programs. And during that time, the Ounce will talk with one home visitor and one supervisor and one consultant about a case that they're dealing with right then, and it's usually a case that's fairly complicated. So they'll spend 2 or 3 phone consultations discussing that case, and then getting the home visitor prepared to share that case with this group of people. In the meantime, the person who facilitates that will do research on articles that support the information that comes up from the case. So, for example, we worked on a case with a young mom who was hearing impaired as well as cognitively impaired. And that mom was holding on to that baby and doing a great job of parenting, but her mother kept interfering and wanting to take over because she was used to providing support to this young lady. So we got articles on what it's like to parent when you have hearing impaired issues, issues related to mom and maternal grandmother in the same home with a child. We got all these articles. The consultants as well as the supervisors were able to read through those articles. They pull us all together, and we meet by in 2 locations and connect with teleconferencing. And we had an article discussion on all of the things that we learned as we read through those articles, and then the person presents the case. And we do not do anything more than connect the article to the case and then support the person who presented the case. It is an awesome learning opportunity and one that I think would benefit anyone who wanted to do something like that in their area.
Thank you, Linda. That was really helpful. It does sound like a tremendous opportunity. I know when we were having our call last month talking about early childhood mental health consultation, several questions had come up around financing. So Linda, I was wondering if you could talk for just a moment about funding of consultation, knowing that it's different in different parts of the country, but how it works in Illinois.
It is. Every program has a different way of funding their consultation work. And the work that we're doing right now is funded through McV. So we are, like I said, we're in like 49 different home visiting programs right now providing consultation, but that is funded through McV. Although all of those sites are not specifically McV sites, some of them are ones that we've been asked to provide some consultation around a maternal depression curriculum called Mothers and Babies. So we go into those sites providing that. So that's one funding source. And of course, many other consultation services can be provided through your governor's office, your early childhood supports through whichever federal or state offices. And there's home visiting consultation provided to Head Start through that federal avenue. And we have private funders in our state that also look at supporting this. So we have the Healthcare Foundation and the Harris Project, the Irving Harris Project. So there are, you go out and search for ways to make that happen. In Illinois, we just submitted, well, not just, but maybe in October, submitted an 1115 waiver to our Medicaid, hoping that that will pass, and included in that is a funding source to continue consultation. So being active and reaching out and touching your funders and making a case for consultation and seeing if there isn't a way to blend some funding with your private and your public partners seems to make a difference.
Great. And I guess along those lines, what the programs that you described, I think the full model in Illinois has a lot of different components. You mentioned your quarterly groups, there's monthly work, there's individual meetings, there's all sorts of different pieces. Does that look pretty much the same across the different sites, or do some choose to just implement pieces? And how does that work?
Yeah, it really isn't the same. It's individualized, just like consultation is individualized. And the model is where we want to end up. If we, we used to receive funding through the Department of Human Services, where we had funding to present consultation to programs, and we would put out an RFP, and programs would write and apply, and then we would select them and fund them. But we don't have a budget anymore in the state of Illinois, so that doesn't happen anymore. But when we did it that way, We presented that full model and said, this is how we're going to do consultation. If you want to be a piece of this, we will eventually do this whole piece. But we were controlling that, and we were also piloting and evaluating the model. However, in the real world now, with that type of structure, when we go into a program to provide consultation, we take it as we can. So if a program says, I'm ready to start, but what I want right now is for you to join our team meetings and meet with our supervisor, that's what we do. We continue to talk about, there are many parts of this way of approaching consultation, but many times we don't get there because what they get is what they needed. And so it's what works for that program. And that's been an adjustment for many consultants because we were used to doing things a certain way. But it has to be fluid, and it has to be meeting the needs, just like home visiting does. We want to meet the needs of our families, so we want to meet the needs of the program.
Yep, that makes sense. Always comes back to that relationship piece.
It
And
does.
so I know that some of the folks that we have on the line are, in a variety of different settings. Not everyone's in a setting that has home visiting. We have, different early childhood system of care sites, and some folks might be on here that actually aren't specifically doing early childhood work, but are just interested in it. Anyone have any questions or, thoughts that are just coming to the top of mind about ways they might like to, explore this kind of infusion? I just want to remind you, you have a wonderful resource on the line. Linda has been doing this work for a long time and has given it a lot of, as you can hear, really creative thought about how to sustain and how to keep these programs moving. So I just want to make sure everyone has a chance to ask her while you have her. Give everyone 1 minute to think if there's any other lingering questions. If not, that's fine too. Okay, well that is not a problem at all. I want to let everyone on the line know that we will have our next learning community in another month, and it'll be at the same time, and it'll be the last Monday again, which I believe is, next month is February the 20, I think it's February 20th next month, but we will send that out to double check, and we will be talking through workforce issues. Please do feel free if you have thoughts, if you have questions, if you have specific topics that you would like to see us cover in this forum. We are really open to your thoughts and ideas. This learning community is designed to be very responsive to whomever it is that chooses to participate. So we're kind of taking it 1 month at a time. So we're going to do workforce in February. We might do kind of a 2-part series on that just because there's a lot to cover there. But let myself know, let Neil know if there's anything that you'd like to hear from, any specific topics that you'd like to hear about, or if there's a different format, something that you think might work better for you. Apologies again about the video. I do hope you take, the video is about 4 minutes long, definitely worth your time. If you have a minute to look at that, I highly recommend. So I want to thank Linda so much for your time, for sharing the model in Illinois. I hope that everyone enjoyed hearing about it.
Thank you.
Of course. So if nothing else, we will give you 30 minutes back in your day. Great. So we will. Thank you so much, everyone.